morning, everybody, and welcome to the presentation that we're having today for our capstones. My name is Dell Gilbert. My presentation is on simulation, building competence and confidence in nursing students. The next slide, I'll just tell you what I'm going to tell you. My full name is Dell Gilbert, just so if there's somebody in the room that doesn't know me. I was born and raised in Portland. I live now in Binghamton, New York. I work two jobs. I have a part-time job working at the Doctor School of Nursing at Binghamton University as a clinical instructor, and I also work at Wilson Hospital in the Chest Pain Center Cardiac Care Unit. My education background went from 1989 as a nursing assistant. I got my CNA through OC at BOCES. 91, I went to BOCES to get my licensed practical nurse. Worked as an LPN for 10 years. In 2005, went and graduated at Tompkins Corning Community College with an associate's in applied science and nursing, and then finished it with a bachelor's at Utica College in 2010. And here we are in April of 2015. Hopefully, we will be graduating for our master's in nursing education. So that's basically what that is. So I'm going to just give you a brief rundown of where simulation came from with some dates, because I thought they were really interesting, and it kind of brings us up to why I wanted to do this. Back in 1928 to 29, there was a guy named Edwin Link who built the first blue box in his basement of his father's house in Binghamton. He then went on in 1931 to become a full-time flight instructor. In 1934 to 38, military decided to use simulation to help not just to keep the military personnel safe, but also kind of understand what they could do about different environmental issues that they could come across, like going into the desert or going into the mountains and so forth and so on. In 1957, Johns Hopkins had the external defibrillator made. In 1958, NASA started introducing simulation to the astronauts. And then Laerdal began the research and development of the mouth-to-mouth mannequin. At this time, in 1960, resuscitation in Annie came into play. And what they used the Annie mannequin was for the medical staff, nurses, doctors, nursing assistants, to have that understanding of how to do CPR, the basic BLS, which helped increase or decrease mortality, and lives were saved more. So then once that was going around, then they started the general public and introduced it to the general public on the mannequin, and that also doubled more, and more lives have been saved from just the general BSL. And then from 1960 to 2002, there really wasn't a lot of changes going on with simulation. But to be honest with you, simulation has been going all the time. We have gaming, which is, if you look at your PlayStation 4, your Nintendos, your Xbox, your cell phones, and you're playing those games called, let's see, I can't think of the games.
Candy Crush.
Candy Crush. Those are all simulation. It's basically giving you some kind of knowledge that, okay, if I do this color, then I'm going to get to a higher level. So it's giving you that kind of knowledge, maybe not as we want to, but it gives you some form of confidence and competence in what you're doing. And then in 2002, basically, the nursing decided to implement into their programs. So what is simulation? Simulation is an activities or event that mimic real life. Okay, it provides the opportunity for students to think critically, problem solving, and clinical reasoning with the care of a diverse patient or population in a non-threatening, safe environment. And then with simulation comes fidelity. Fidelity is just basically how real that simulation is. There are 3 levels of fidelity under simulation, okay? And they are low fidelity, medium fidelity, and high fidelity. So low fidelity to me, I remember being in the LPN program and how back in the 1990s we had oranges and apples and we used doing our injections with them. That right there to me is like low fidelity. You're not really critically thinking, you're just doing the task, okay? Medium fidelity is using a plastic arm that has the veins, the locations, and what that's trying to do is tell the student, okay, you have, given a scenario saying, okay, you have a patient that needs to go to the CT for contrast, and where you're going to put the IV, what size of the IV needle is. Do you want to go to the distal end for this, or do you want to do the proximal side? Do you want to do a 20 or a 22 or an 18? So that's the part where that the two-dimensional, they have that, they need to know that critical thinking. They need to know, okay, what would happen if I stuck it here and the contrast blue, what's going to happen? So that right there gives the student a little understanding and try to create some kind of giving them the making of their decisions kind of thing. And then the high fidelity is basically a human patient simulator that will, they can have it talk, they have breath sounds, they have a blood pressure, they can sweat, they can bleed, you know, so it's just, it makes it, the level of activity heighten, okay? So then what I was thinking is, as I was looking as a clinical instructor, I see these students come into clinical, and I can tell they stand there, they look like little deer in headlights, okay? They're like scared, they don't know what to do. I remember a couple weeks ago I had students come to me and like, the patient's got a chest tube and I'm supposed to get him up. Okay, so what's the problem? What's going on? Well, I don't know. I'm afraid that that's going to fall out. I said, okay, so let's talk about it. And we went and we talked about it, and then we got him up. But they lack that confidence, and they lack that competence because they go from a theory class right into the clinical, and they don't have that in between, so they can get that understanding that, yeah, you can get them up, and this is how we'll do it. And if, just in case that chest tube comes out, what are we going to do? What do we have that we can make sure that they're okay, they're safe? So that was my problem statement. That was the problem, is that the students come to clinical, they have lack of self-confidence and they have the lack of competence. So the purpose of my research is to examine whether simulation will increase the student's competence and confidence by the end of the nursing educational program. So that was the purpose of my research. My research question that I had was, does early implementation of simulation in nursing curriculum versus traditional curriculum, or traditional use of simulation at the end of the junior year, influence students' competence and confidence by the completion of the nursing education program? So that was my question. Now, how a lot of people says, well, how do simulation kind of work with nursing, and how does it all come into play? So what happens is that there's 4 components of simulation. We have pre-briefing, we have the simulation scenario, we have the debriefing, and then we have the simulation evaluation. So the pre-briefing is basically giving students a little information of what's going to happen in that clinical situation. Okay, so then they can go home, they can read up on the information, they can anticipate of what's going to happen in that situation and what they may need and what type of skills. And then when they do, they come into the simulation, and then they just do the simulation, finish it up. It takes about 20 minutes, depending on how and what type of simulation it is. And then we sit down and debrief. And the debriefing part is actually taking time to reflect up what we did well, what we could have changed and what we can make better. And then we kind of take that outcome and we build on the basic of the knowledge. So whatever they have thought was going on before the simulation, then we bring it up higher by bringing more information to them and having them understand a little bit better. And then the evaluation part of it is just evaluation the simulation experience, students' behaviors, and how their student learning outcomes are. And I'm stuttering. Okay, so I'm going to give you an example of how this works, okay? So the pre-debriefing, what we'll do is the week before, that week before they go to simulation, we put it on Blackboard that, okay, you're going to do a Foley catheterization. So we're going to give you evidence-based practice from sites that are our go-to that we look at. Like for an example, like we were going to do a Foley catheter. So what we do is we give them information from the CDC. We show them how to prevent. The website provides a great page discussion for infection of what happens when you're putting a Foley in and what type of infection you can get, and how to prevent these infections. And then we give them videos so they can watch. They have the option to go in a couple days before the simulation and practice. They get a little checkoff sheet and they go into practice. And then after that, when they get that done and they feel confident, when simulation comes on, say it's Thursday, they come in and of course they put the practice of inserting a Foley. They're in the room by themselves or with another student, depending on what's going on. They do the simulation, and then after the simulation is done, we go into what's called debriefing. We sit in a group. This is students are the ones interacting. The professor sits out on the side here and listens to the conversation. It's all students. They talk about what they done, what they felt was good, what they felt needs improvement, and so forth. If there was a significant problem, like say that one of the students cross-contaminated the field, so what we would do is put it on the computer system and we watch a video of what they did, what they were doing, and then we would say to them, okay, so as we're looking at this video, what do you think is going on here? Did anybody pick up anything? And then we would talk about it. And that's what debriefing's all about. Okay? So we learn from each other, and then then after everything is learned, then the educator starts talking about, okay, so the basic part of the simulation is to make sure that we're not cross-contaminating, that we're doing proper hand hygiene, that we're, so forth and so on about that information. And then comes, after the students finish the debriefing, finish up what they have to do that day, they go home and they have 24 hours to do an evaluation. And the evaluation is basically a Likert scale. It goes from strongly disagree to strongly agree. And the only thing that they have to do is click on 1 through 5, the numbers, and answer these questions. And then at the end, there's an open box that you can add comments like, oh, I would really like to have maybe somebody who has a congested heart failure, and how we're supposed to give meds and stuff like that. And you can add what you would like to see in the future about a new simulation. So then I was thinking, after this simulation, I was like, okay, what theorists would be good for this the simulation? And what I came up with is Kolb's model of experiential learning. And he wrote that learning is a process whereby knowledge is created through the transformation of experience. And that knowledge results from the combination of grasping experience and transforming it. So I was like listening, I was kind of reading this over and over because at first I didn't understand what Kolb was trying to say to me. But then I was thinking, he basically is saying the same thing as what we were doing in simulation. And we'll get, as I go further into this, I'll explain more. So I just this is his quote, and basically it was supposed to have been like 2 sentences together, but it came out this way, and I apologize for that. So Kolb's model of experiential learning has 4 learning stages. So the 4 learning stages starts out with, and why does it go all the way down? Has concrete experience, which is actually the doing, the having the experience kind of thing. So, like example for our Foley catheter, they go into the simulation lab, they do it. So there's your first step, okay? Then you have the reflective observation, which is basically reviewing and reflecting from that experience. And I like to put the reflective and the abstract conceptualization together because the abstract conceptualization is the concluding of actually learning what you've experienced. So I thought these two would go together because you're in the debriefing point and you're learning, okay, this is how I'm feeling, this is what I've done, this is what I could do better. And then you're thinking to yourself, okay, so I've done this, so I should be able to conclude that, I do have the confidence, I do have the knowledge that I can do this in the nursing. And then your final stage would be the active experimentation, which is basically planning it and then going out and doing it into your clinical setting. So that's how I thought simulation and the Kolb's model work together. And then the next one is basically just the circle of how it actually works around. Okay, so as I was looking through my research, I came up with how I wanted to make sure that my research was strong enough, and what I did was I looked at the literature review, and I looked in Sinal, ProScrat, yeah, I'm stuttering, I'm so sorry, ProQuest, and so I looked at the articles in 2008 through 2013. They were all in full text. Some of them were scholarly articles, and they were all the English language. My keywords were simulation, nursing students, competency, and confidence. The evidence were basically randomized control, quasi-experimental studies, systematic reviews, and descriptive studies. And as I was looking at the evidence-based, I have 2 of them. I have 4 slides that I'd like to show that deals with my research. And 2 of them were descriptive, and the other 2 were actually statistical. So the first research that I did was Yan, Hott, Williams, and Feng. And this basically talked about the learning process with nursing students. It showed, it was determined whether this, there was a, yeah.
We're all sitting here naked though. We're all sitting here naked.
Okay. They basically were in a safe environment, and they wanted the students' ability to notice and interpret the response appropriately to the patient care situation. And the environment was found, that the safe environment, that the simulation environment was founded, that the students acquire and incorporated cognitive, psychomotor, and affective skills, which in this process found that the increase of the students' confidence and competence increased. And so that was pretty, it was like a low evidence base, but it was still pretty strong, I think. And then the other literature was on Bambi, Washburn, and Perks, and this was 2009, and showed that creating a realistic simulation during which nursing students can develop and demonstrate clinical judgment without endangering real people. So basically the same thing, in a safe environment, it's not a real person, but it can simulate that is a real person, and it showed that the student had improved their self-confidence and competence. Another one, and I hope I say her name right, her name is Eltz, I think. She's 2011. She did a quasi-experimental study, and she evaluated the comparison between simulation and the regular skilled laboratory, and that in promoting the students' competence and confidence. And what she did, and the results demonstrated statistical significance in the student's competence and confidence during and after or after the simulation experience. And then the one that it stood out really well because this is a real good literature, was on Mold, White, and Gallagher, and they examined 210 students who actually was an undergraduate that did a critical care simulation. And what they showed that pre-simulation students' confidence was 2.3 and the competence level was 2.51. After the simulation, you could see that the confidence of the students were 3.75 and the competence was 3.71. Okay, and as you can see, statistically, there is an increased significance in the competence and confidence after the simulation. So overall, I just wanted you to know that the literature does support early simulation. It increases the student's confidence and confidence. And that's why I just put it short and sweet. So then my research and how I want to bring it together is I'd like to probably see if BU would let me do this, is that I'd like to design my research as a quantitative study, quasi-experimental, descriptive. I'm going to measure the competency and the confidence from the beginning of the nursing school until graduation. The tools that I want to use is the Modified Lassiter Clinical Judgment Rubric, which is basically the competent part, and then the Student Satisfactory and Self-Confidence in Learning Questionnaire, and that is the self-confidence tool. And the samples that I want to try out is 2 groups of 20 students. They'll be male and female. I'm going to take one part and have them start at their freshman year. So when we start the first nursing about how to bathe somebody and how to take care of a geriatric patient, I want to start the simulation with that component right there. And I want to go through the whole year until they graduate. And then my second 20-year students, I want to wait until like their junior going to their senior year and have that part there and see at the end how their confidence and competency is at the end. Of course, my demographics would be age, race, gender, and ethnicity. Because these are human subjects, I have to have IRB approval. My collecting of the data will be informed consent. Each simulation will be monitored by the researcher and videotaped, using videotaping, sorry. My data would be collected by 20 freshmen and from the simulation experience from the starting of the nursing school to graduation, and then the second one would be from the junior year to the senior year to graduation. And then I would compare those two to see if early simulation is more effective in their confidence and competence versus waiting until the end of their junior year. And then, like I said, these are just pictures of my tools. I'm sorry that they're blurry, but this is the Lassiter, and that's the student's self-satisfaction and self-confidence in learning questionnaire. And then, how would I wrap everything up? How would I bring all my information up? With basically these two instructions, they're databases. They're basically what is it called? I can't think. Excels. These are Excels. This is an Excel that helps with quantitative. So I take all my quantitative data, stick it in Excel, and it kind of gives me the interpretation of what's going on. And then this is my qualitative. I put my qualitative information into this. And it'll give me my bell curve, my whatever I need to present it in a statistical manner. And I think that's it. And then I have my references. And then before I finish my references off, I just wanted to say thank you to Deb Gates, Diane, Sue, Joanne and Vicki for helping us out. And then I'd like to thank Patty Ruther and Lori for my clinical experience that I got with them. To my cohorts, helped me to get through this, and to my family, Gary Mars, and my sister and my nephew, Seth. And any questions?